Welcome, dear audience, to another educational session. Today, our topic of discussion is about immunosuppressants in ophthalmology. They are used quite frequently nowadays in immune-mediated diseases along with steroids, and they are very effective. But it is very important also to consider certain protocols. So, in order to discuss, we have once again invited and requested Dr. Mansfield Smith from Ipswich Hospital, UK. Dr. Mansfield has extensive experience as a consultant medical ophthalmologist in management of thyroid eye diseases, vasculitis, uveitis, and immune-mediated diseases. When I was thinking about this topic, I thought that she would be the best person as she has extensive experience in the use of the immunosuppressants in management of these complicated diseases. So now I will invite her to please present her talk and educate our audience. Yes, Dr. Mansfield Smith, please.
Thank you very much, Dr. Mirza, for the very kind introduction. Yes, I'm passionate about treating patients and caring for patients with complex diseases such as uveitis and vasculitis and thyroid eye disease. And I'm going to share with you and your audience today some pearls of wisdom regarding the management of these cases. So I really hope you and your colleagues find this very informative. So my talk today is going to be on the eye and immunosuppression, risks, trade-offs, and uncertainties. So first of all, I'm going to talk a little bit about the historical context, overview of immunosuppression, and then some short case vignettes illustrating risks, trade-offs, and uncertainties. So some background. So it was Hippocrates and Galen who first documented general ocular inflammation, and then later an Italian anatomist, Antonio Scarpa, first described uveitis as a distinct disease in 1806. Then in 1873, a Dutch ophthalmologist, Dr. van Doormaal, first described ocular immune privilege. He actually did this by accident. He was trying to find the underlying cause of cataract, but he discovered that tissues like mouse skin and tumor cells lasted for a very long period of time when transplanted into the anterior chambers of other animals. He never found the underlying cause of cataracts, but he inadvertently found ocular immune privilege. But it wasn't until decades later, in the mid 20th centuries, when treatments started to emerge, such as steroids, then later in the 60s, traditional DMARDs, and then anti-TNF therapies towards the end of the 90s and early 2000s. So when we're thinking about treatment, we think about ascending the treatment paradigm. So the first step even is acute control with steroids. These can be topical, they can be intraocular, periocular, or systemic. During this talk, I'm just going to focus on systemic treatments. So they work rapidly, but they have toxic side effects. So regarding their long-term use, you really want to taper down the dose to 7.5 milligrams or less within 3 months. If this is not possible, then you need to move up the treatment ladder to step 2, which is first-line steroid-sparing treatment, such as antimetabolites or less commonly calcineurin inhibition. These include, the antimetabolites include methotrexate, mycophenolate, and azathioprine, and we'll talk a bit more about those later. But these take time to be effective, up to 12 weeks. So you need to wait, and if they're not effective at 3 months, then you need to be thinking about moving up to step 3, and that's a biologic DMARD. The first line in uveitis is usually anti-TNF therapy. So step 1, steroids. How do these work? So they enter the body, they then bind to intracellular glucocorticoid receptors, and they form a steroid receptor complex in the cytoplasm of cells. This then enters the nucleus of cells and it modulates gene expression, inhibiting pro-inflammatory genes and activating anti-inflammatory genes. And this has a multitude of effects on reduction of synthesis of inflammatory mediators and suppression of immune cell activity. And this results in very broad anti-inflammatory and immunosuppressive effects. Some practical considerations when using systemic steroids. So once again, the good point is that they're really fast acting. But in elderly patients or patients with comorbidities, and especially when you're using high dose intravenous treatments, you may need to do baseline bloods, consider a chest x-ray, and potentially an ECG. You need to counsel patients regarding the side effects of these treatments, provide written information to patients, and you may need to assess their fracture risk, and we use the FRAX score in the UK. You may need to prescribe bone protection, gastric protection, such as a PPI, and monitor cardiovascular risks. And there is sort of consensus guidelines that recommend you tapering down patients with uveitis to 7.5 milligrams or less of oral steroids within 3 months. And there is the ostrich trial that was the ocular inflammation steroid toxicity trial, which was a UK-based multi-center trial that showed 33% of uveitis patients exceeded this safety threshold, and this therefore put them at risk of other side effects such as bone density loss, cardiovascular risks, and gastric risks as well. But you must remember that if you are moving on to start a DMARD, patients may need still ongoing treatment with steroids, and these side effects will need to be managed. With steroids, there are a multitude of potential side effects, but I'm just going to focus on bone protection for an extra minute or two, because sometimes clinically there is some confusion about who needs potential treatment with bisphosphonates. So we know with bone remodeling, there's a delicate balance between the osteoblast cells, which are the sort of bone forming cells, and osteoclast cells, which are the sort of bone breaking down cells. But steroids disrupt these cells and can cause bone mineral density loss. In the UK, there are sort of nice guidelines that tell you who is at risk of osteoporosis and also who would benefit from immediate starting of these therapies. So generally, if patients have been on long-term steroids for more than 3 months and they're a woman who's postmenopausal or a man who's over 50, you can just start these treatments with bisphosphonates, or patients with other sort of high risk factors. But if you're starting treatment with steroids in a patient and you're not sure about their risk factors or whether they're high risk and would qualify for treatment, you can use the FRAX score. You can Google it. You need to put the country that you're in into the calculator, and then you put in their risk factors, and then it will generate a graph, as you can see in the bottom corner, which tells you whether they're low risk or whether they need a bone density scan or whether they need immediate treatment. And if they have a bone density scan, you'll get a report in the UK, which will tell you if they're osteoporotic or penic, and advice and guidance about treatment. There are a few other points about FRAX, though. If you're using this scoring system, it is designed for patients over 40. You do need to give very clear instructions of how to take bisphosphonates to minimize side effects, and you should avoid in pregnancy as it can cross the placenta and cause abnormalities. There's long-term retention in bones, which is a good thing in some ways because it means once this treatment is stopped, it still continues to have effect. But you do need to have caution in premenopausal women, as there still is a potential risk to pregnancies even after stopping this medication. But it is still balanced with the fact that if they are at risk of osteoporosis, you still need to assess this risk. There is general, obviously, sort of conservative management that you can advise patients with, ensuring they have adequate calcium and vitamin D in their diet, that you encourage weight-bearing exercise and minimize alcohol and smoking. So step 2 of the treatment ladder is starting a traditional DMARD. DMARD stands for disease-modifying anti-rheumatic drug. Most commonly, these are the antimetabolites, which are methotrexate, mycophenolate, azathioprine, or calcineurin inhibitors, which are lesser used, but tacrolimus or historically cyclosporin. I'm going to spend just a little bit longer talking about the anti-metabolites. These are the most commonly used with uveitis patients. So there was the FAST trial, which is the first-line anti-metabolites as steroid-sparing treatments, which was an RCT to compare the effectiveness of both methotrexate and mycophenolate in uveitis. And there were two sort of cycles of this trial, one in 2014 and one in 2019. They both showed the effectiveness of methotrexate and mycophenolate in uveitis patients. And there was in the data seemed to suggest that methotrexate could be slightly more effective for posterior or panuveitis and mycophenolate for intermediate uveitis, but these results weren't statistically significant. It did show that there could be successful switching between DMARDs, particularly if switching from mycophenolate to methotrexate. When mycophenolate had failed, patients could still have gained control on a DMARD if they were changed to methotrexate. And generally, starting these medications improved quality of life for patients on these treatments. Methotrexate is given once a week, either orally or subcutaneously, and you do need to prescribe folic acid on a non-methotrexate day. Mycophenolate is an oral daily medication. They have some similarities in side effects, but some differences as well. I tend to find the methotrexate patients have a slightly higher risk of developing abnormal LFTs. Mycophenolate in clinical practice, I see more patients complaining of GI side effects, though if these are mild, because a lot of patients will complain of feeling nauseous or off their food, but usually I find this subsides after about 6 weeks. Azathioprine is the lesser used anti-metabolite, but it does have proven efficacy in Behçet's disease, but it's generally inferior to methotrexate and mycophenolate in broader non-infectious uveitis. Once again, this is an oral medication given up to a maximum dose of 200 milligrams daily, but it has an advantage over the other two as it's relatively safe in pregnancy where the others are not. But it does need extra screening. You need to screen for TPMT activity to ensure that you can give this medication to patients safely. So if you've decided to start one of these patients in your uveitis patients, remember it's patients you can't wean to a low dose or off oral steroids. They do need screening tests, including blood and viral screens, and they do need warning about potential side effects, which includes risk of infection, fertility for both men and women, immunizations, alcohol, and there are various other side effects you need to discuss, and also give patients appropriate leaflets. There's also an increased risk of malignancy, particularly non-melanocytic skin cancer, so you need to give appropriate sun protection advice. To ensure that patients are followed up and monitored appropriately, we use a database that's securely stored. And with certain patients, we can also send out shared care guidelines to GPs to ensure their ongoing prescription of treatment. And it's important to have support either from a specialist nurse and the wider team to make sure monitoring is ongoing. So step 3 is the biologics, and the frontline biologics are adalimumab and infliximab. So adalimumab is a fully humanized monoclonal antibody, which is administered subcutaneously at a maintenance dose of 40 milligrams biweekly. The key clinical trials on adalimumab were the VISUAL-1 trial that showed its effectiveness in active uveitis, VISUAL-2 that showed its effects in inactive uveitis and with patients on steroids and they were able to wean off steroids, and VISUAL-3 that showed its effects in its efficacy in extended treatment. Infliximab is also an anti-TNF treatment, and it's a chimeric human and mouse monoclonal antibody. It's administered intravenously. Dose is based on weight and severity of disease every 4 to 8 weeks, but it can also now be given subcutaneously. It has been shown to be highly effective in refractory cases and other systemic diseases like Behçet's. And it's associated with a good response, but there's higher baseline immunogenicity due to its murine components. So with biologics, you'll often see that they're not prescribed as monotherapy, or they may be in certain cases if patients have had side effects on DMARDs. But you'll notice that they're often prescribed alongside a traditional DMARD like methotrexate or mycophenolate. And this is because these drugs, they suppress B and T cells, which are responsible for the creation of anti-drug antibodies. And this is a reason why sometimes there's failure of the treatment, failure of treatment on anti-TNF later on down the line is because patients have started to develop these antibodies. But prescribing either a full dose or low dose methotrexate or mycophenolate alongside a biologic is protective against this and helps the ongoing efficacy of this treatment. So I've got a few cases now to share with you. So the first one will demonstrate ascending the treatment ladder and then descending again. So this was a lady in her 30s who presented to the eye clinic with blurred vision and floaters. On systems review, she'd had a non-healing genital ulcer, a joint pains, erythema nodosum, and she had a history of mouth ulcers. She'd been struggling with infertility but not had any miscarriages. Her vision was down in the right eye at 6:30, left eye was 6:6. Her intraocular pressures were normal. She had a mild AC reaction on the right, but no hypopion, no posterior synechiae. Left AC was quiet. Right vitreous haze was noted, left vitreous was quiet, and these are her OCTs. On the right, which is the superior image, you can see that there's marked macular edema. Inferiorly on the left, you can see the OCT of her left eye, and this showed a normal foveal contour. These are her Optos images. There's no signs of vasculitis here or choroiditis. There's a slightly hyperemic disc on the right, left eye grossly normal, Optos imaging unremarkable. This patient was started on topical steroids, then oral steroids, and a PPI for gastric protection. She said initially of the steroids, it really helped her floaters and her blurry vision. But then she started to notice a blurred patch in her right eye. And this is her FFA a few weeks later after starting systemic steroids. So you can see on the right, there is diffuse leak, but also a pinpoint area of hyperfluorescence supratemporally. On the left, grossly normal findings. And she developed CSR. And even though when we tried to take her off steroids, her uveitis would return. So this is her clinical progress. We did a full uveitis screening. We found she was HLA-B51 positive. Given her symptoms and signs, we diagnosed Behçet's disease. She was on oral prednisolone but developed CSR. She had retinal subthreshold laser and was started on azathioprine as we couldn't wean her off the steroids. Every time she came off, her inflammation returned. Her systemic symptoms responded very well to azathioprine, but her uveitis was poorly responsive, and she was then started on adalimumab. And this is just to show you that the guidelines for the treatment for Behçet's from the British Society of Rheumatology, and we're looking at the ocular arm here. So we've given her steroids, we've started her on an anti-metabolite, and then we've gone up to anti-TNF therapy. So her disease then goes into remission. Her vision is 6:6. She's off steroids and then off topical treatment as well. And she's seen about 9 months later, she's on her azathioprine and she's on her adalimumab. And she comes to clinic and she's very happy. And she tells me that she's now pregnant. I just want to give people a moment to think, what would they do next? What are you considering? And what if, given what you're doing next, what if her uveitis flares? Okay. So we need to then think about immunomodulation in pregnancy. Azathioprine, as I mentioned earlier, is relatively safe in pregnancy. Adalimumab also is, but if used in the 3rd trimester, there is placental transfer and baby cannot have live vaccines for the first 6 months. You can avoid that by trying to stop the medication prior to 28 weeks. If after stopping, because we are now stopping treatment, if she flares, steroids are relatively safe, but we would need to check that she doesn't develop CSR again. However, generally in pregnancy, women become hypoimmune. So they're naturally immunosuppressed. Okay, so she may not flare at all. It is important with cases like this that you have MDT management, and maternal medicine is involved with this lady's ongoing care. Case 2. This is a very short case, but this shows what withdrawing treatment may reveal. So this was a gentleman in his 60s who had a history of panuveitis and had been diagnosed with sarcoidosis. He had a right nephrectomy many years ago due to RCC, and he had a background of diabetes and hypertension. He had previous bilateral cataract surgery, previous oral steroids, intravitreal steroids, and was established on mycophenolate 1 gram twice a day and had been weaned off his steroids. So he'd gone to step 2 of that treatment ladder we'd shown earlier. His uveitis was in remission. He was very happy with his vision. But he developed lower limb cellulitis, so his mycophenolate was stopped and he was given antibiotics. After his infection had settled and he was off antibiotics, we did discuss restarting mycophenolate, but he was quite anxious about restarting this because of his recent cellulitis. So we agreed that we would monitor him and, if necessary, start him on topical or intravitreal treatment. Then about a month later, his vision started to become hazy and he noticed some more floaters. Active inflammation was noted, more so on the right than the left. We started topical drops and then gave him a right Osidex and requested an FFA and ICG. So 3 months later, his hazy vision and floaters had increased. His right Osidex was only partially effective. His vision actually remained very good, and he only had mild anterior inflammation, but his main issue was posterior changes. He had an evolving choroiditis in both eyes involving the macula. I immediately restarted him on oral steroids, and he agreed to restart his mycophenolate, and we did further baseline bloods. However, given the results of these bloods, he was admitted to hospital that night. So he developed acute kidney injury. His eGFR had dropped to 16, his creatinine had climbed to over 300, and he had a spike in his calcium also. So he had a flare of his ocular inflammation and also a deterioration in his renal function. He was admitted under the medical team. They stopped his ACE inhibitor and his metformin for 2 days. And they looked for causes of his acute kidney injury. There was no evidence of dehydration, or there'd been no changes in his medication. Yes, he'd had an infection, but this had been some time ago. And there was no signs of post-renal obstruction either. So this was likely that his sarcoidosis, because he was off treatment, was now affecting his kidneys. So yes, no other signs of or causes of renal dysfunction were identified. And because of the steroids, there was rapid recovery of his kidney function, and this normalized again. He was restarted on his mycophenolate, prednisolone withdrawn, and his uveitis was controlled with no further episodes of either flares of uveitis or renal dysfunction. So just a few brief notes on systemic sarcoid. We know this is a multi-system disease. Commonly affects the lungs, and we see them in the eye clinic because of their ocular manifestations. Patients may have complement levels, they may have 24-hour urinary calcium levels done, bone profile, a baseline ECG, with further cardiac investigations if necessary. They will have histology and ACE levels done, and you can always discuss these patients at an MDT if needed. There are various types of renal involvement, and this can affect, depending on what you read, roughly around 30% of patients. So the point is that I want to make about this case is when you're withdrawing systemic treatment, even if you only started this because of ocular manifestations of a disease process, when you're seeing them at follow-up, you do need to inquire also about potential systemic symptoms and monitor for other systemic symptoms that may manifest after you've withdrawn systemic treatment. So case 3, risks and trade-offs. So this is a gentleman in his 70s who has a background of bilateral retinal vasculitis and stable MS, but previously this had been described as neurobehcets, and he had a long history of ocular symptoms and procedures, initially with optic neuritis in the 1970s, hemiparesis in the 80s, and he'd had vitreous hemorrhages, vitrectomies, cataract surgery. He'd had peripapillary CNV and panuveitis in the past. And he had recurrent episodes of quite marked ocular inflammation that unfortunately had caused scarring and loss and deterioration of his vision. His treatment, so he was at this point in time on tacrolimus, 2 grams twice a day, and prednisolone, and cardiovascular medications and medications for his prostate as well. And here's a summary of his treatment. So he'd previously been on azathioprine, but he'd had side effects on this, and he'd been on various doses of oral prednisolone, and had been intermittently on tacrolimus. But every time he came off his tacrolimus, unfortunately, he had a flare of his inflammation. So this was at a routine follow-up. He had a baseline of count fingers vision on the right, left eye best corrected of 0.4, but generally controlled posterior inflammation. This was an FFA that I did to look for deeper signs of inflammation because I had concerns he was developing side effects of his immunosuppression. So he had developed 2 skin lesions within a fairly short period of time, one on his temporal area, which was red, raised with scaling, which was a squamous cell carcinoma, and also a BCC. So what can we do in a case like this? We know that his systemic immunosuppression has increased his risk of skin cancers, non-melanocytic skin cancers. So we discussed other options of treatment with him. We could go back to intravitreal therapy. He was really adamant and against this because he'd had it in the past and he felt it hadn't helped his vision or stopped him losing vision in particularly his right eye. We discussed changes of systemic treatment, but once again, they all have a degree of a risk of malignancy. And once again, he was adamant that it was the tacrolimus that had helped maintain his vision or decrease the dose potentially. So we did go down the route of decreasing the dose very gradually based on his serum trough levels. And he has ongoing follow-up and close monitoring with dermatology. And I did offer him a second opinion from other specialists, but he was happy with this treatment plan. With cases like this, you just need to have a frank and honest discussion and remind patients about the side effects of their treatment. So why is there a risk of non-melanocytic skin cancers in patients on medications like tacrolimus? Well, this is dose and duration dependent, and we have a lot of information, particularly from patients who have had solid organ transplants. And the risk is related to multiple mechanisms. So there's suppressed immune surveillance. There's also, because of immunosuppression, oncogenic viruses can cause genetic mutations, which can lead to predisposing to skin cancers. And also, we do know that obviously UV radiation can, in any case, cause increased risk of skin cancers, but this seems to be accentuated with patients on these types of medications. There's also the disabling of the suicide genes, the p53 pathway, which would usually cause death of abnormal cells. And so there's this direct tumor growth, proliferation, or promotion on these medications. So my take-home messages is counseling pre-immunosuppression is really important. So patients are aware of side effects, and you need to have ongoing monitoring. You need to look for patterns and review potential systemic side effects. And also remember that a patient's situation or condition may change, which would then mean that you need to review the patient's treatment plan. Thank you very much. And these are my references, and I'd be very happy to take a few questions.
Well, Dr. Mansfield, it was a very interesting presentation, and you explained almost all points. And nowadays, it is quite commonly these are used medications as immunosuppressants. But a few things I just want to discuss with you, that when we are using these immunosuppressants in long term, so talking about their safety and efficacy, what difference do you feel between conventional antimetabolites like methotrexate, mycophenolates, or biologics? Particularly now we are having adalimumab for specific uveitis phenotype. So when we talk about the long-term safety and efficacy, what is your opinion?
Thank you for that. So that is a really good question, but just going back to how these drugs work. So they work in different ways. So their safety profile differs. So when we're thinking about anti-metabolites, they tend to have more organ-specific potential side effects like hepatotoxicity, GI side effects, effects on the bone marrow, potential renal side effects. So you do have specific monitoring guidelines to try and identify patients who may develop these, and then, if needed, change their treatment. As for biologics, because they are sort of, particularly we're thinking about the anti-TNFs, they work through a slightly different pathway. So they have their own sort of safety profile. And things we're particularly worried about are infection, so particularly reactivation of latent TB. There are specific neurological side effects. We're thinking about cardiac side effects. So they also have a very strict patients who need these treatments go through a very strict pre-screening assessment to check for any of these potential risks and mitigate and manage these. Thinking about their sort of safety profile in uveitis, we still follow that treatment paradigm I talked about earlier. So generally, we still start with steroids because they're fast acting, then move up to anti-metabolites or potentially calcineurin inhibitors, and then on to biologics. There are a few exceptions to this, but generally we go through this pathway. But if patients have a particularly sight-threatening condition, sometimes we do jump almost straight to biologics, particularly in very severe phenotypes of Behçet's. And remember, with biologics, there's also this extra risk of patients developing anti-drug antibodies. So actually they work well together. So if as long as the patient can tolerate it, having a low dose or treatment dose anti-metabolite alongside the biologic will work to ensure the ongoing efficacy of treatment.
Well, Dr. Mansfield, one thing more, when we talk about the duration, what is the optimal duration when we are using these systemic immunosuppressants, particularly in achieving durable remissions and minimizing cumulative organ toxicity and infection risks? So that is an important thing which comes to physician's mind.
Yeah. So obviously there are many different causes of non-infectious uveitis, but when we think about sort of ocular or idiopathic uveitis without systemic disease, generally we're looking for at least 2 years in remission off steroids. So that would be either on a DMARD or DMARD and a biologic. And then you would consider gradually withdrawing treatment to see if you can maintain remission. Obviously, you'd need to monitor them more frequently as they come off treatment. To ensure that they're not flaring. If they have an underlying systemic condition, it depends what that systemic condition is, because they may be under a rheumatologist as well, and they may need to continue their treatment because of their underlying, say, joint disease or vasculitis. But this is where communicating with other departments and telling them your ocular findings and maybe managing the patient as part of an MDT is important to, once again, just like you said, to make sure that they're not unnecessarily continued on ongoing treatment to lessen their systemic side effects from these treatments.
Yes. Of course, it is a team effort in collaboration with rheumatologists and other teams, very important in the use of these immunosuppressants. And we also here in our hospital, we take quite frequently their opinion when we are managing these patients, and under their guidance and their suggestion, we manage and follow their protocols. One thing is, Doctor, about Mansfield, about failure. For example, in patients who have established anti-TNF treatment, but how do you manage secondary treatment failures due to the presence of anti-drug antibodies? Sometimes these antibodies do develop and the failure is happening. What is your experience about these things?
Yeah, so that's a great question because it can be very disappointing for the patient and also the clinician when patients have seemingly done well on a treatment like an anti-TNF and then it seems to become ineffective. So first of all, you want to just clarify that that is the reason for secondary failure. It's not an issue with compliance. So you would do drug levels, you would do antibody levels. And once you've confirmed your suspicion that there are, it is due to the development of anti-drug antibodies, if they've had monotherapy biologic, you could add in still trial adding in a DMARD, a traditional DMARD like mycophenolate or methotrexate. But if they're already on that, in any case, you could consider switching to a different anti-TNF. For example, if they've been on infliximab, you could change them to adalimumab, or if that's still ineffective, you could change to a different biologic altogether, which targets the different so has a different molecular target, such as anti-IL-6 drugs like tocilizumab. But yes, it is a difficult situation that will require extra thought and planning. Thank you.
Right. Well, Dr. Mansfield, it was a very interesting talk, and you explained the questions and answered in detail. And I believe this presentation will be very beneficial for our physicians all around the world who are managing these things, and it will be beneficial in their clinical practice. And I want to thank you on the behalf of our own international virtual audience that you have accepted our invitation to educate them. And we are looking forward to more educational sessions to learn from your experience and knowledge. Thank you, Dr. Mansfield.
Thank you very much. It's been a pleasure. Thank you.